Cool. Well, welcome back to the podcast. Thank you. Thank you guys for tuning in. This is Ben, your host, here to explore the depths of healthcare. Today we have a new guest. Shelley has a very unique product, very unique business that he is leading the charge on, and I'm very excited to have him discuss his history as well as the different innovations that are being made by his business. Shelley, why don't you introduce yourself?
Ben, thanks for having me on your podcast. Hi, everybody. I'm Shelley. I'm founder and CEO of Sevamob. We are a US-based Delaware C corporation with a fully owned subsidiary in India, and we provide an AI-assisted disease management platform to organizations.
And how did you come around to developing this and have the vision for this? Like, what led you to start this business?
So I started my career in IBM, where I did product development, and then after an MBA from Cornell, I managed multi-million-dollar products in the mobile software portfolio. And something happened at that time, which was an episode with my mom, where she was incorrectly diagnosed and almost lost her life because of hepatitis C, and was the impetus to do something about this problem. And I started from India, where we launched a technology-enabled primary healthcare service in 2 towns in rural India, with an idea to increase access to care, improve diagnosis, and improve treatment times in those areas. So that's how we started. Initially, this was a B2C service where our patients were rural families on a subscription model. And very quickly, we realized that the model would take much longer to scale and become sustainable. And so we switched to a B2B model where we started selling this service to employers and to schools. And then the second learning was that we can increase our average revenue per user and increase our profitability if instead of doing general primary healthcare, we split our service into more specialized services. So that meant splitting into general health and vision and nutrition, cardiometabolic, and infectious disease. So that made us sustainable. And at that time, we were doing technology-enabled mobile clinics. And then our customers asked us for telehealth for between the mobile clinic visits. So typically, the mobile clinics visit weekly, monthly, quarterly, or annually, depending upon what the objectives of the intervention were. And so between their visit, then our patients started accessing the service via telehealth. Now, we do offer video consults and second opinion and just phone-based audio advice. But given that majority of our patients are low-income patients in underserved areas, uh, in telehealth scenarios, phone-based advice tends to be the most popular option. So we kept offering that along with technology in mobile clinics. And around 4 years ago, we ventured into AI space, and we were one of the early adopters to develop models and deploy this in low resource settings. And the impetus was for example, in low income patients in developing countries like India, malnutrition is a big problem, but dietitians are hard to come by. And oftentimes, when diets are available, they are expensive. And oftentimes, advice they offer is not standardized. So we developed a diet AI, which enables nurses to predict multivitamin and mineral deficiencies and recommend a diet plan. And that was our first medical device, which was a class 1 medical device. And in clinical studies, it improved BMI in 13% of the adult patients when the diet recommendations from AI were paired with behavioral counseling and supplements. Then another problem in India and other developing countries is tuberculosis. India has one of the highest disease burdens for tuberculosis. But there's a lack of good screening mechanism for TB. There are very good molecular tests for confirmatory, but they're too expensive to be used in a screening scenario. So we developed our sputum AI, which enables a nurse to screen for tuberculosis in sputum samples. Just last month, we added to that our chest X-ray AI, which enables a nurse to screen for tuberculosis in chest X-ray images. And so now we have a very well-developed triaging and screening portfolio for tuberculosis. So one thing led to another, and now today we have 8 AI-based medical devices, 4 of which are Class 1 devices and 4 are FDA Class 2 devices. So apart from Diet AI, and the second medical device we have, which is a Class 1 device, is the Symptoms AI, which enables the nurse to predict medical conditions from symptoms. And we use it. It's actually the most used device we have currently. And we are using it for triaging very frequently in the field, which is physician level triage that can be done by nurse. Then the third device is the medical evaluation AI, which lets you assign a health score based upon the complete medical record and then make recommendations for your health. And then the fourth one, which we are shortly releasing, is Lab Report AI, which enables you to summarize a lab report and then make recommendations on what steps you should take based upon that lab report. So these are all Class 1 devices. Our Class 2 devices, the first one was Sputum AI, second is Blood AI, which screens for iron deficiency anemia. Third is Vision AI, which screens for diabetic retinopathy. And then fourth is the chest X-ray AI that I mentioned earlier. And you might ask why we chose these specific use cases. And the
Sure.
answer was very simple. These were the requirements we saw in the field, whether from our patients or from the B2B payers that we have. And that's how we develop one medical device after another based upon anchor tenants.
So it sounds like you were very much listening to the atmosphere in a sense. You were listening to what the needs were and going where that led you. Is that correct?
Absolutely, Ben. And I think part of the reason for that is apart from being close to our patients, but part of the reason is while we have raised a couple of rounds of equity investment, most recently in January of this year. But if you don't have too much funds, disposable funds at like your beck and call, right?
Yeah.
Then you are more selective in what you do and how you do it. And that in our case turned out to be like a boon and a blessing in disguise that we had to be very selective of where to deploy those funds. And that's why we chose this path versus building a beautiful platform, like then going out and trying to find
Sure.
customers.
Sure. So you guys found yourself to be very flexible because that's what I'm hearing. You were very easily able to pivot and to see needs and to address those needs pretty quickly. Is that correct?
Absolutely, man. And I'm sure you've talked to other founders, and one of the key things you have to have in a startup is the ability to pivot and to innovate and change based upon what your customers are telling you, what the market is telling you. And that turned out to be the case in our case also. So, and the other thing is, while we are, the parent company is a US based LMSE corporation, one of the reasons we are in a developing market is because the regulatory burden is less in that market. So we can innovate much faster. While we do follow all of the laws, like HIPAA laws and things like that, but we have the flexibility to innovate faster in that market. And so that also helped. I'm sure if we were in this market and with limited funds at our disposal, then we would be innovating much more slowly than we have been able.
Mm-hmm. That's what actually my next comment was about. I think because of meeting those needs in the developing market, I think you've had the ability to develop so many different pathways at this point. I'm also really intrigued who, for sourcing your AI kind of overreads on chest x-rays and sourcing your AI, like who, do you have a team of in-house developers? Is this your specialty? Kind of who are you working with an outside entity? How does it kind of connect?
A good question. So we actually, because of my own technology background, and I have a very good team which is based in India in a tier 2 city. And so we are developing this in-house. And we have good access to data because in our mobile clinics, for example, we do around 72,000 plus patient consults per month. So, and to date, we have done since inception around 4 million patient consults. And since the beginning, we have like stored the data meticulously. And we also have like, good partners because of our reach, which is now in 20 plus states of India and in Bangladesh. So as you know, in AI and as you develop or even test the models, the more data you have, that becomes a strength for you. And in our case, just given our model, if we were, let's say, a brick and mortar type of a business where we were just fixed clinics waiting for the patients to come in, our patient footfall would be, let's say, like 10 to 15 patients a day, right? On a good day. But in our scenario, this is a mobile clinic model. We are seeing around 80 patients on average per team per day. And we currently have around 270 full and part-time teams deployed across different areas that we cover. So that data gives us the the resource that we use to train and will test the model.
Yeah, the more data you get, the better it learns, and then everything gets optimized and just learns from itself. Yeah, totally makes sense. You now talk about the support team of the physician role. You're talking about the nursing role who can kind of use symptom AI or medical evaluation AI. Do physicians have a role, or does this seek to maybe push physicians and providers out? I'm curious, is there a synonymous pathway? What's your take on that?
That's a great question, and I have written an article on this also. We think of AI as something which improves the productivity of frontline workers.
Mm-hmm.
It does not displace physicians, or it does not displace a given type of a medical professional, but rather makes them more productive. Right. So we are developing specifically modules or AI tools which enable a nurse or a health worker to do more protocols at point of care than they would otherwise be able to do. And which helps us do that first level triage, that first level consultation better, cheaper, faster than our competitors can. But in healthcare, because of the regulations, there always be a doctor involved in that workflow,
Mm-hmm.
right?
Mm-hmm.
So at the same time, in developing countries, the patient footfall is just too much for a doctor to manage everything on his or her own.
Yeah.
So this makes a doctor's job much easier if the nurse does the initial triage, nurse does the initial point of care like nurse screening, then the doctor's job actually becomes much easier. And at the end of the day, the prescription has to come for the doctor for the treatment. So
Totally. Yeah.
we're not trying to replace the doctor. We're trying to make his or her job much easier and faster.
Let me delve a little bit into that specific category. Have you enabled AI to be able to help? I mean, if these physicians are signing prescriptions or writing prescriptions for 80 patients a day, and doing 80 notes per day that they have to sign and put their name on for legal purposes, do you have AI to support them in that hemisphere as well, to be able to transcribe the notes, to be very compiling all the, whether it be chest x-ray information, laboratory information, and compile that all into a document, into a chart note?
That's actually an interesting question coming from, I'm assuming you're based in US, right? So you're
US
coming
based,
from
yeah.
background. So the documentation requirements are much more onerous for the physicians in the US, right?
Mm-hmm.
But in other markets, like in India, doctors don't have to document as much,
Okay.
especially in a primary healthcare setting, right? What we do instead in our workflow is to reduce that burden even more, because we want that very expensive and very scarce resource, which is a doctor, to be used solely for the patient and patient care, right? So
Gotcha.
that documentation part of the flow, we have offloaded to a data entry person. And so, yeah, so the nurse and data entry, they do a lot of documentation, while the doctor is free to engage the patient and provide the best quality of care to the patient. So spend more time with the patient rather than on documenting in the system.
Mm-hmm.
Is how we have developed our workflow in that market. Now, yes, we have developed two different processes where, first of all, from day one, since our inception, we have developed this software of which one of these AI tools are part of, which can run offline in a low resource setting.
Mm-hmm.
The data can be entered on the keypad, or the data can be dictated and then automatically it can do the voice to text in the system. And that
Mm-hmm.
we're not adding anything special. It's just the Android capabilities which allow you to do the voice this thing, or the manual typing, right, keyboard typing. So those features have been in the system from inception, and they have made the job of the physicians much easier in that scenario. But the physicians themselves do not enter that data, the support staff.
As a medical provider, I want this.
I hope you can understand, because my wife is a physician and she practices in different hospitals in Atlanta. And one of her pet peeves is that she spends so much time dealing with the EMRs and the data, those EMRs, right? She wants that time to be freed up and take care of the patients. But when there's a reason for that, for liability reasons, she just has to spend that time.
We were all told the same thing when we were getting into medicine, and I'm sure she was as well, is that with the technology advances, it frees you up to spend more time with the patients themselves, actually listening to their concerns and maybe being able to address things that they didn't actually show up for, but you can actually give them the time and space to share those things, whether that be an outside social concern or whatever it may be. It sounds like your model is giving that space for the providers and for the
Yes,
clinicians.
and one advantage of using AI is because you input certain stuff in the system for the AI to make its decision or make its recommendation. The AI can, based upon how you do your prompts and everything, it can provide very detailed responses, right?
Mm-hmm.
And you store those responses. So automatically, as part of the workflow, there's a lot of data being captured, which you don't have to manually enter, which you end up doing in your normal workflow, right? So the AI actually helps in documentation from that sense that every patient engagement and every recommendation from that is just increases the quality of the data.
Yeah, I mean, it's incredible. And yeah, I wish we could adopt this more in the US. Is it mostly regulatory issues and kind of slow movement and adoption in the US that kind of prohibits from using the model that's being very effective in India and other developing countries right now? Would you say that's the
So
primary thing?
no, so in our first of all, the platform we have done pilots in the state of Georgia in the US, and those pilots were successful. But think of it like this: so our initial investors were all impact investors because they saw the applicability of the model in a lower source setting, right? And in underserved areas. And so our first responsibility is to our shareholders who wanted us to use that for impact in those type of settings. So that's how we started, and that's how we designed from the day one on issues which were for developing markets and also settings and underserved areas. Right now, several of our tools can be used in a developed market like the US. So tomorrow, if our shareholders they prefer or they want us to enter these markets, we would obviously be here. And there's nothing which restricts the technology or the model per se from operating in this market.
Okay.
But we have limited dollars. Those dollars are currently deployed more fruitfully, generating higher ROI in a market like India or now we are in Bangladesh, and we have done pilots in South Africa and Lesotho. So that dollar can go much farther in that market than in this market.
And so what I'm hearing is that the shareholders are very, very much more proactive on getting as much return as possible.
Social return.
Yeah,
They are
exactly.
social impact investors. And so their focus is on lives of low income patients improve. A number of female patients in that setting whose malnutrition would improve, right? Number of children whose malnutrition improve. A number of I don't know, so those type of health outcomes are of lot more interest to them. And that's
I
what
agree.
we try to do.
I agree. It seems like, I mean, from my perspective, you're bringing good to the world. You're bringing an opportunity into healthcare that previously, I mean, there's a massive need, and so you're meeting that need with the tools that are developing in health tech and using AI. Is that correct?
That's correct. And from day one, our thinking has been that while we can serve low income population or a developing country population using a non-profit model, but if a for-profit social enterprise model is going to be much more viable long term. And that's what some of our peers have also discovered, that while they started as a non-profit, now some of them are adopting a hybrid model. And so in our case, that's why these investors joined our journey and became part of our story, because they thought that this would be more sustainable. And today we are EBITDA positive. We are generating free cash flow, and that's just a big goal of our vision from here.
Yeah, because of the vision, but also stepping through with it. I think you've developed what it sounds like a really, really effective team. Do you have other plans for? I mean, you already have what, 8 applications of AI at this point with the new chest X-ray, tuberculosis screenings. Are there other applications that you guys want to delve into, or are you like, whoa, we have 8, this is good for now, let's stay with this and kind of make these more effective?
So our roadmap has growth in 2 different directions. One is to improve and increase our AI portfolio, and that means developing more of these medical devices and adding support for more medical conditions in existing medical devices. So, for example, today in blood AI, we support iron deficiency anemia. But with the help of new foundation models now, we can add support for other types of anemia. at least of interest to us are 5 different types of engineer, right?
Hmm.
So that's one way where in existing models will add support for more medical conditions. And then the second, like an approach would be to add new models. For example, we want to analyze ultrasound images over time. And
Hmm.
because that can help us like detect a lot more or skin for a lot more conditions
Hmm.
at point of care. Portable ultrasound devices is like a very useful device in that like setting.
Hmm.
So both increasing the medical conditions in existing devices and new devices will be like our approach when it comes to expanding our AI portfolio. We're just getting started in this space. There's so much we can do from that perspective. And the second is to expand our coverage area. So
Hmm.
from inception, we started like, in 2 towns in India. And now we are in 20 plus states in tier 1, tier 2, tier 3, and rural. And
Hmm.
especially we differentiate ourselves because of our coverage in tier 3 and rural there. Then earlier this year, we replicated to Bangladesh. And we developed, deployed AI-based malnutrition intervention method there with a partner. We also did pilots in Southern Africa earlier. This was a couple of years ago.
Hmm.
And there's also actually something interesting which I would love to share with you. So we did like experiment with different models of how to enter a new market because that was the first time like we had entered a new market, and as you can
Yeah.
imagine, it's challenging. So initially we got into that market through a franchising, and there were challenges both in the responsiveness and speed, and also accounting practices, which and so we said, okay, we already have like a good initial set of customers, so let's see if we can do it ourselves instead of doing it by a franchising. But when we tried to do it ourselves in that new market, we got bogged down with regulatory compliances, labor laws, and things which were not like in any way helping us improve the healthcare, but more about just like having a company registered like there.
Right.
Then we pulled back from that decision and we said, okay, we'll just do it via local resellers and partners instead of like doing this. So there was a learning involved, which was I think a 2 to 3 years process in that new market. And so now for new coverage areas in like new international markets, our approach is we will license our technology platform to local partners. We will provide point of care rapid kits to them
Hmm.
and provide our panel of telehealth specialists to them, because that, in our opinion, addresses a lot of like pain points in those markets,
Right.
and at the same time is a more scalable model than us trying to like do the whole thing ourselves in that market, or like they work very deeply like we tried to do it earlier. So we think that model would replicate and scale much faster and would be like much cheaper for us.
And it will be, I feel like it would be easier to adopt in these different places rather than
Absolutely,
running
yeah.
into all the walls that you were hitting.
Absolutely. And it's a very, um, especially for this type of replications, you want a very cookie cutter model, right? And
Hmm.
so this is exactly where it is. Like, here is our technology platform. You choose which one of the AI tools you want or patient data management tools you want from that.
Hmm.
It's all cloud based, it's all SaaS, very like, point and click. And by the way, I know you want to test for 20, 50, 30 conditions. So for that, you can also like, source these rapid kits from us. And so here are the like kits which will ship to you from India.
Yeah.
And by the way, I know that many of these markets don't have like, they have a scarcity of specialists. So we can provide to you those specialists over telehealth and while you use your local MBBS doctors to like write prescriptions and stuff. So
Right.
that's the approach. We'll see like, how well that works. But I think that is much more scalable.
Would you say that that is rolling out soon? I mean, obviously you tried in South Africa and have learned from that experience. Would you say you're starting to market this effectively to different countries or different rural
Yes.
communities?
Yeah, so we already, this is the model we are trying in Bangladesh, where we have
Hmm.
the first partner who has deployed this model. Shortly, we hope to replicate this with a second partner there.
Hmm.
And we have current ongoing conversations for countries in sub-Saharan Africa on the same model. And I think that's going to be a much better use of our time as well as precious dollars than trying to like, enter the
Yeah.
market ourselves.
And now, for me, for the audience, I am trying to understand that are you offering this service to already like clinics that are already providing healthcare for their patients? So you're selling to those private clinics or to the healthcare systems that are in those places? Is that what
Correct.
I'm? Okay.
Correct. And so while we can partner with any organization as long as they have access to captive, like patient audience or patient population, but what we've seen is it does help if that organization or partner has a medical background, right? So ideally, somebody operating their own clinics or diagnostics or a pharmacy chain would be ideal partner. And if any of your audience is listening to this podcast, we would love to partner with them. Please do reach out to us.
Yeah, absolutely. And I'll make sure that we'll have links to your website and links to connect with you guys, just attached to the podcast, attached to the description as we get this kind of as soon as you get it posted. Shelley, any other thoughts? I did have another thought of, you've already told me some of the headaches you were having, but what are kind of some 10,000-foot view pain points that you're seeing just in the business right now?
I would say given that our business model is B2B, so in a B2B business model, there's a payment cycle involved. So in our case, one of the pain points is the short-term working capital to address that payment cycle. And in a developing market, if say you're not putting a collateral, then the interest rates you're paying are very high. So in our case, for unsecured debt, for short-term working capital, we have to pay as much as 18 to 19% with all the transaction fees and interest rate included. So that increases the cost for everybody involved, right? And not just for us, but also for our paying customers, right? We can reduce the cost for them if this was cheaper. So that also limits how fast we can grow. We are growing, we are replicating, we are developing our tech at a very fast pace. But given the challenges of that short-term working capital, there's only so much we can grow and so fast we can grow. So
Definitely.
that would be number one. And number two, one of the reasons I reached out, called out to your audience earlier was to replicate in a new area, which is one of our key objectives. We need local partners, and getting good quality local partners who have the relevant background is always a challenge, and that limits how fast we can replicate and where we can go. So those are the two main challenges we are seeing right now. Given where we are. See, we don't have challenges when it comes to technology development. We have a pretty good handle on that. As I explained to you earlier, we don't have challenges when it comes to data procurement. All of that, that's actually our strength. We also don't have challenges in hiring medical professionals. 272 plus full and part-time teams serving 95 plus B2B customers in different areas. We have more than 40 doctors on our payroll, more than 40 nurses on the payroll, and a lot of other support staff. So that's not a challenge, but the challenge remains on what we can do to grow faster in terms of business.
Yeah, definitely. No, thanks for that insight. It's helpful to kind of get a perspective of, from my medical provider perspective, I see it as, man, you should be in every developing country at this point and have every private health clinic using this format. It would make everybody's jobs easier. It would help more people, and you're doing it for the good of the people. You're meeting needs that haven't been met before. That's why I ask on the podcast for the audience as well, to kind of get a better understanding of, there are good people attempting to serve other people in this world still, and your business is absolutely attempting to do that and attempting to bring healthcare to people who might not have ever had access and would never have had access in the past.
Yeah, and another, let's call it a challenge or a change which is required in the system is, since as you know, not just in the US, but in these markets, government is one of the biggest payers, right, or biggest buyers, right, in these markets. And a lot of government RFPs are still not as technology focused as they should be, or at least oriented in that way, right? So if those things can be added to the RFPs, it would help in increase in the adoption of not just AI, but other technology advancements, right? So that's something which will happen over time, I'm sure. There are changes happening, but it can happen faster. I mean, there's a room for improvement.
Where do you guys, so bigger picture, where do you hope to see, let's call it 12 months, where do you hope to see Sevamob in 12 months from now, looking back, and what the positioning looks like at that point?
12 months from now, we would, instead of trying to be in too many different places, we'll try to go deeper in where we are, deeper and wider where we are. I think that would be the best use of the scarce resources that we have. What we have seen in the past is some of our peers, they try to just for the sake of brownie points, saying okay, they're in this country, in that country, in 10 different countries, right? But um, if the market is big enough and you have not fully penetrated that market and you're a small player in that market, you should see what is wrong with your business model that you're not able to improve your penetration in that market
Hmm.
instead of trying to to put a band-aid on that problem and then going to a new country. A new country possesses presents new sets of challenges,
Hmm.
um, whole different set of rules and regulations, and you can get a bigger bang for your buck if you figure out how to improve your penetration in existing markets before entering new. The other part of our roadmap will always be just keep putting out more of these AI-based devices and improve their adoption.
Hmm.
More POCs, do more pilots with them, get more uh, uh, new devices on the roadmap. Right, that's where given to be improved.
Absolutely. Yeah, it's difficult when a lot of these rural places just don't have access to technology. Period. You know, and that's why you're offering the telehealth. But it would be much better to collect a lot more data if everyone had the same access. But we can only control so much.
Absolutely, and being in the US, you have the advantage that the audience is a lot more technology savvy, right?
Hmm.
But in places like India or Sub-Saharan Africa, there's less awareness about new technology in the buyers, right? So oftentimes what we do is not a technology-led pitch. What we do is more of issue-led pitch or value pitch, where we say, okay, we are going to improve your malnutrition for this patient population by X%. And that is a better enticer for them than us going and saying, oh, we have this tool AI which can do XYZ, because that's not going to generate the right response. So that's the other thing is to have the right messaging for the market in which you're operating.
Right. Absolutely. That can speak to a lot of different things, a lot
Yeah,
of different
absolutely.
businesses too. Any closing thoughts, Shelley, that you would like to share with the audience, to the listeners?
What I would say is AI is here. AI is here for good, and you can use it, or you can be left out of the whole value chain, which is now fostering. In healthcare, that AI is going to be used to improve productivity, to improve access to care, to reduce the cost of care, and to offer more protocols at point of care to the patients. And so I think the very good use case of AI in healthcare, medical professionals should not be afraid of using it and think that this is going to displace them. What they should instead think is that earlier they could serve, let's say 10 patients in a given hour or in a given day. But this is going to help them serve, let's say 5x those number of patients.
Hmm.
And earlier they could do three things with those patients. And now this is going to help them do, let's say 5 to 10 things with those patients. So that would be my closing message with the audience, that at least in healthcare, there is less need to be afraid of AI, and rather than talk it with open arms. And the second message would be, and this is just something which we did recently in our in the team, um, the patient care is just one aspect of how AI can improve the providers in this space. Now, what we started doing is we started using increasingly ChatGPT in our own business processes, with non-healthcare delivery business processes. So, for example, for writing new sales proposals, for new sales presentations, for sales emails, right? For cost sheets and stuff like that. And there, this AI has dramatically improved our turnaround times. It has improved the quality of proposals that we are doing now. It has improved. It has reduced the error rates in those proposals.
Hmm.
It has just improved the overall productivity of all of my team. So don't think of AI in healthcare as just a way to improve patient care. AI in healthcare can also be used to improve your regular business processes, whether it's billing, whether that is your administration or whatever else, or sales or marketing.
I agree. No, thanks for sharing that, Shelley. Really, really grateful that you spared the time. Honestly, I feel very special that you were able to join us today and share about the good things that you're trying to bring to this world.
Thanks, Ben. Thanks for having me on the podcast.
Absolutely.